So it's my pleasure next to welcome Suhaini Kadiman to the stage from Malaysia. I understand Dr. Kadiman's from the National Heart Institute in Malaysia, has a particular interest in the neurocognitive effects of cardiac anaesthesia, and in collaboration with Yaya has developed a Malaysian arm to SPICE, about which he's going to tell us now. So, welcome.
Good afternoon, everybody. When Yaya spoke to me about SPICE about 2 or 3 years ago, I was rather skeptical in the beginning. Well, this is because the Australian practice and the Malaysian practice is obviously widely different. We spend about 5% of our GDP for the healthcare cost as compared to Australia, and most of the initiative in intensive care units are physician-led rather than nurses-led initiative. This is my hospital, National Heart Institute, Kuala Lumpur. It's quite a rather busy hospital. We perform about 10,000 cardiac procedures a year last year, and about 4,000 cardiac surgery a year last year. So the skepticism about duplicating SPICE in Malaysia initially is not because Yaya's protocol and ideas is not good. Obviously, we have seen his presentation and we know that the protocol is extremely good, but it's rather about the logistic issues in Malaysia and the challenging about networking, developing networking among the Malaysian doctors. Malaysia is a not so small a country, and when the senior physicians in Malaysia managed to persuade me to participate or conducting this SPICE, I sent the emails to 15 intensive care units throughout Malaysia, and surprisingly all 15 intensive care units were interested, but only 11 of them give their commitments. And therefore, we proceed with 11 intensive care units throughout Malaysia. They were widely spread throughout Malaysia. What we had is actually quite a representative of the entire Malaysian practice. The issue of the practice, the current practice of sedation in Malaysia is a very important issue. Generally, we do not monitor the sedation practice in our ICU. If they were monitored, the tools chosen were different. Most of the hospital chosen the Riker sedation scale. We do not look into delirium in our ICU. If you look into delirium, it's rather doctors' initiative rather than nurses' initiative. And of course, we never look into the association of sedation and mortality. So this is rather an important change in our practice throughout Malaysia. And SPICE is not only another research that we conducted, but has been taken as the radical approach to change in practice in sedation throughout the ICU in Malaysia. So the training was done on site. You can see Yaya's face in everywhere. We have make him a rather busy person, traveling him from one end of Malaysia to the other end of Malaysia. But at the end of the day, we managed to motivate the nurses to become the leader in managing the sedation in intensive care units. We managed to change the tool that is being used from Riker to RASS to accommodate for the protocol. We managed to teach them and teach ourselves how to monitor delirium and how to diagnose delirium using the CAM ICU. And they are all motivated and certified at the end of the training program. And this is, I guess, is the most important thing, that the ownership of the program is all belong to the participating investigator rather than some other studies led by some other investigator from some other country. That is really important thing. So what we found is that comparing the Malaysian data and the Australian data, well, the age is about, we are relatively, the patients were relatively younger. The male and female distribution were the same. We were a bit smaller than the Australian. Aperture score were the same. Elective admission and emergency admission to the ICU were the same. The average length of stay is about the same. Hospital length of stay is shorter in Malaysia. Ventilation days was about the same. We use more vasopressor. We perform more renal replacement therapy. However, we perform less tracheostomy in our ICU. And when we perform tracheostomy, they were slightly at later stage in the ICU. The ICU mortality and the hospital mortality was rather striking. This is due to the fact of, the GDP used to develop the ICU throughout Malaysia is not that really a significant portion. And therefore, initially I thought to look into sedation practice is rather difficult because nobody will understand that sedation will give a major impact. But when we found this, we were more convinced that we have found something really important in our practice. So we have recruited 259 patients. There were total of 2,657 ICU beds with total sedation days of 2,439. There were 13,000 over, almost 14,000 RASS assessment and 1,500 over CAM ICU assessment. Majority of us gave midazolam to our patients. When it comes to the choice of analgesics, morphines were the first choice rather than fentanyl. 40% receive midazolam, about 31% or 31% receive fentanyl or morphine. Only a small component or small proportion of our patients receive propofol as compared to the Australian data. This is similar to what has been shown by Yahya. Majority of our patients were deeply sedated when they were first assessed in the ICU. And again, up until day 3 of assessment, they were still majority deeply sedated. Our overall incidence of delirium were slightly less as compared to Australia. Well, maybe the pickup rate is lower, knowing the fact that the nurses were recently trained. But this is really good that we can pick up 44% of them that had the overall incidence of delirium, and the incidence of delirium increased as the stay in the ICU increased. The Kaplan-Meier survival estimates predicts that the early deep sedation predicts the delay in the time to extubation, and it also predicts the higher 180 days mortality, which is very much similar to what has been shown by Yahya. So the multivariable Cox hazard regression analysis also found that the early deep sedation was independently associated with increased time to extubation, hospital death, and 180 days mortality. The Apache 2 and dialysis were also predictive of time to extubation. Age independently predicts 180 days mortality. Early deep sedation was not predictive of time to delirium, while the cumulative dose of midazolam in the first 48 hours predict the number of RASS deep sedation. It was not associated with the time to extubation, delirium, or death. And dexmedetomidine in the first 48 hours was predictive to time of delirium. What is more important, from the outcome of Malaysian SMICE is that this provide a good ground for the future collaboration between the Australian intensive care practitioners and Malaysian intensive care practitioners. So I think we are looking forward for future collaboration with Maya, hopefully, and we have shown that we have a group of enthusiastic local PIs, and our demographic data were about the same as what has been shown from the ANZ SPICE. I would like to thank Yahya for his confidence in me, all Malaysian PIs, Research Department, National Heart Institute Kuala Lumpur, and the ANZ Research Center for making this a success. Thank you very much.